talk a full hour?
It doesn't have to be.
Like, so if we started at 5 after?
Sure.
Okay.
Yeah.
Okay.
I think it's you like. You like me?
That's fine. I remember you got stuff on the wards and people trickle in. Sure.
Well, that's not the policy trend.
BGHICU has got somebody to obviously. One's coming down.
Sure. Let's go for it. All right.
Morning, everybody. Welcome to the Division of Rheumatology. It seems to be half the audience this morning. I apologize. I guess people will trickle in, and it's been, well, in any case. Welcome to a new year, and the Division of Rheumatology is starting off the new year, and looking forward to a talk today by Jonathan Chen, one of our previous residents, fellows, and now on staff, about spondylitis. Jonathan?
Thank you. So as Dr. Casson mentioned, I'm a rheumatologist. Practice across the street from Vancouver General, and have clinical and research interest in spondyloarthritis, and we have a newly established psoriatic arthritis clinic as well, which I run with Dr. Yan Wang. So today I want to talk about classification, get everyone, all the non-rheumatologists in the room up to speed with where we're at right now in our understanding of spondyloarthritis, how we make a diagnosis, present some of the data that we have been working on with this SASPIC trial that was presented at the most recent American meeting, some new imaging modalities, another study that we're working on to utilize low-dose CT, and new treatment options as well. So some disclosures: I've participated and received funding, research grants and advice for a number of pharmaceutical companies. So what is spondyloarthritis? It's an autoimmune inflammatory arthritis of the spine. Typically involves the low back, buttock/hip. 99% of people are going to present with back pain before age 45, which isn't that helpful because most mechanical back pain also presents in the younger years as well. And it occurs in roughly 0.5 to 1% of the general population. So if you look at older studies where they pretty much just said you had an spine if you had a bamboo spine and fused SI joints, and the prevalence is about 0.1. But if you incorporate some of the newer imaging modalities, some of the newer classification criteria, a number of studies around the world have suggested the numbers pretty much equivalent to rheumatoid arthritis, and previously thought to be mostly a male disease. The most recent data out of admin database out of Toronto looked at classic Eng-Spawn cases, and it was about 3 to 1 male. But if you start factoring some of the new criteria, including MRI positivity, that's thought to be closer to 1 to 1. And females tend to be less X-ray positive and more MRI positive. There's a huge delay in diagnosis, on average about 10 years in delay from symptom onset to making the diagnosis. And I want to distinguish, there's axial spondyloarthritis and peripheral. So I'm going to be focusing mostly on axial, which is inflammation in the spine, but a subset of them can also get inflammation in the peripheral joints. And we think psoriatic arthritis is kind of a cousin disease, and that's kind of the classic peripheral spondyloarthritis. But for today's purpose, I'm going to focus more on the spine. So here's an older study from 2000 looking at the delay in diagnosis. And so, can you see this arrow? Yeah, I think you can see this arrow here. This, the pink dots are the females and the blue dots are the males. You can see this is when the symptoms started and when diagnosis was made. And there was a bit of a delay between when the men were diagnosed and when the females were diagnosed. More recent data out of Europe suggests that delay is much shorter, but the awareness of spondyloarthritis is much more prevalent in Europe because there's a lot more. A lot of the spondylitis experts, international experts, are out of Europe, and so the Netherlands and the Germans have rapid access clinics for spondyloarthritis. So their average delay is about 3 years. I think Canada we're closer to the 10-year. So how does this manifest? 60% of the time, patients will only have back pain. 40% of the time, you're lucky and you'll have something else that kind of clues you in. So if you follow, this is before we had better therapies. We kind of had these long-standing cohorts, and we know that roughly 30% of patients untreated will get a peripheral arthritis, like a big, hot, swollen knee, typically large joint oligoarthritis asymmetric, uveitis, about 30% lifetime risk. And that risk goes up with time. So if you look at the incident cases, about 15% prevalence of uveitis, but as you follow them with time, the cohort eventually develops uveitis in about 30%. Enthesitis, so where the tendon inserts into the bone, is very common. And so classic areas would be plantar fasciitis, Achilles tendonitis, golfers and tennis elbow. Part of the issue is that this happens to a lot of people. If anyone runs here, I'm sure you've had plantar fasciitis before. So just having enthesitis alone doesn't mean you've got spondylitis, so don't need to worry. But in patients with spondylitis, it happens more frequently and it lasts longer, and it can be quite severe. So in this In this case, you can see that the Achilles tendon here is pretty inflamed. And then ulcerative colitis or Crohn's disease, overt disease is found in about 5% of patients. They've done colonoscopies on patients with ankylosing spondylitis without a diagnosis of IBD, and they find a prevalence of about 60% of microscopic colitis. But the actual clinical significance of that is a bit unknown. We don't know if these people will eventually get it. And there was a fairly recent study called the SPACE study out of Montreal, where they did capsule endoscopy on asymptomatic and symptomatic patients with ankylosing spondylitis. And they found even amongst asymptomatic patients not on NSAIDs, 40% had diffuse ulcerations in keeping with Crohn's disease. And then they had a couple of cases where these patients were not treated. They just kept on etanercept, which doesn't help bowel disease. And they have nice slides where the colon or the small bowel just slowly strictures off. One of the criticisms of that study is that we've been using NSAIDs in these patients for decades. And obviously NSAIDs is not a good thing with Crohn's disease. And yet we're not seeing hordes of Crohn's disease happening. So, it's a bit, we need to replicate that study to know what the actual clinical significance of these asymptomatic colitis patients are. Dactylitis, where you get the sausage digit, so the whole finger swells up, is very characteristic of psoriatic arthritis, but it does happen in ankylosing or axial spondyloarthritis, and psoriasis about 5% of the time. Now, you may wonder, what's the difference between psoriatic arthritis with spinal involvement or ankylosing spondylitis with psoriasis? And, ultimately there's a bit of overlap, and it depends who saw them first. Was it the dermatologist or was it me? And so back in the day, 1984, we had this old classification criteria called the Modified New York. And in the world of rheumatology, the gold standard of diagnosis is a clinical expert rheumatologist opinion. So these are mostly for clinical trials, but they do kind of encompass the thought process that goes on and in our decision making. So in this older criteria, you wanted some clinical features, some inflammatory sounding back pain, some restriction on motion, and you wanted some X-ray damage. So either bilateral grade 2 or unilateral grade 3 or total fusion, and that's what we'd call anti-spawn. Now, in terms of what characterizes an inflammatory back pain history, we know that no single variable can really distinguish the two. So morning stiffness alone, not that helpful. Better with activity alone, not that helpful. But in combination, there is some utility. So, there have been 3 major criteria that have been set out or described that can help to distinguish between inflammatory spine disease and mechanical or non-specific back pain. The Callan criteria is probably the most sensitive, but the problem, if you read it, age of onset less than 40, lasting more than 3 months, insidious onset, and any stiffness in the morning, that's pretty much like 80% of mechanical back pain. So, it's very sensitive. You're going to pick up a lot of AS patients with that criteria, but you're also going to pick up a lot of mechanical back pain patients as well. So this is an X-ray of the pelvis there, and you can see here the 2 SI joints. And, this is the hallmark joint of this disease. Rarely you'll see people who have inflammation in the spine and not the SI joints. It's quite uncommon. So the Europeans did this study. How many MRIs of the whole spine plus the SI joints do you need to capture one patient that wasn't captured on SI joint MRI alone? And the number was, I believe it was 300. So if you do 300 total spines, you're going to capture one patient that wasn't captured on SI joint MRI alone. So this is really the hallmark joint. And this is normal. So you can see it's very smooth. There's not a lot of whitening. There's no erosions and obviously no fusion here. So this is an example of a floridly destroyed SI joint here, bilateral grade 3. So the SI joint here, it's totally ragged. These are all erosions or sclerosis here. And one of the challenges when reading X-rays is bowel gas. So you can see here, this one's kind of in the way. So if I saw this side alone, it would be on the right side alone. I might want to repeat the imaging, but on the left, it's pretty floridly abnormal. This is where it's a little bit more subtle. So I'd call this 1 or 2, probably bilateral 2. You see there's whitening here, the sclerosis, and then you can see there's some irregularity here. But it's a bit subtle, and some healthy people, if you X-ray them too, you might pick that up. So if I saw x-rays like this, I'd want to see something more, like a convincing story and a B27 positivity or some uveitis alone to really clinch the diagnosis. So even since the original modified New York criteria, we've known about X-ray negative disease for a while. So the year after Mohammed Khan published this paper looking at first-degree relatives of classic AS patients, and a lot of the patients had clinical features suggestive of SPA. They were positive for B27, but X-ray negative. And so at the time, we didn't know, were they pre-radiographic and eventually they'll get damage, or is this a distinct subset, or will this kind of burn out on its own? And so we never really knew. And in the 90s, two German rheumatologists started doing MRI, and they found a lot of patients who were B27 positive. Their history was very suspicious. They had some good response to NSAIDs. They did an MRI, and it was positive. It showed some fluid in the joint, but X-ray negative. And so this is an example. So the X-rays here are normal, and this is what we call a fluid-sensitive sequence, a stir, and you can see these white patches here. That's water in the bone, suggestive of inflammation. And then this is the T1, where you can see some, this kind of patchy whiteness is what we call fat metaplasia, and then there's some irregularities here. You can see these subtle erosions here in the right bottom of the ilium, which you don't really appreciate on the X-ray. So they kind of proposed this Bayesian approach where you start off with your baseline probability of 5%. So older studies in Europe, out of England, had suggested in young people under 45 with chronic back pain, the prevalence of spondyloarthritis is 5%. So you start with that as your baseline, and then you add likelihood ratios based on if they have uveitis, if they're B27 positive, if their MRI is quite positive or the X-ray is very convincing. And if you have enough of these, then you come up with a final probability. So you get your nomograms and you kind of move around. So in 2009, there was a new classification criteria that was proposed, which basically was young person with chronic back pain either had convincing imaging plus one feature of spondyloarthritis, such as swollen joints, recurrent enthesitis, uveitis, or B27 positive and convincing clinical history as well. So there's some controversies here. X-rays are notoriously hard to read. There's really wide variability in inter-reader reliability. The first clinical trial, Ability 1, looking at non-radiographic or X-ray negative disease, that was positive, as an RCT with Humira. They by definition, patients were X-ray negative. So when they approached the FDA for approval, the FDA wanted a separate read of the X-rays, and 30% of those X-rays were read as classic AS. And so, it's not necessarily because they were sneaky in letting these people in. It's that X-rays are imperfect. As you see those bilateral 2 X-rays, a lot of radiologists would repeat that as completely normal. MRI and X-rays results are not binary. So if you get a little bit of bone marrow edema, it's very different than florid bone marrow edema with erosions. And then obviously if you're totally fused, that's very convincing. And there's no weighting of features here. So uveitis carries a lot more weight than NSAID response, for example. And then there's very few objective signs of inflammation here. So in AS, in classic AS, about 30% of patients are positive for CRP, and 60% of patients are positive for bone marrow edema. And we know, so Walter Maximovich in Edmonton has done studies where they do serial MRIs in known AS patients, not on therapy, and they do MRIs every 6 months, and you'll see structural damage, so you know they've got AS, and these bone marrow edema lesions will skip. So sometimes they'll be there, sometimes it won't. But it's probably the best test we have to detect active inflammation. Other challenges, so diagnosis is based on an expert opinion, so you shouldn't be going around ticking boxes and saying, well, B27 positive, some heel pain, and NSAID response, therefore go on a biologic. That's not the way it works. And the majority of non-radiographic AS patient or spondylitis patients do not seem to end up having classic AS, as far as we can tell. So this one study in the US by Mike Ward, they followed these non-radiographic patients for 15 years, and only a quarter of them ended up having classic AS. So, and if you look at there's 4 RCTs in X-ray negative disease, and the mean disease or symptom duration was 10 years. So, if you follow them long enough, they don't necessarily get classic AS, and they don't necessarily burn out as well. So this is kind of a graph showing the TNF inhibitors response in classic AS patients. So a 40% response is seen in about 40 to 45% of patients. and definitely different than placebo. And if you look at the X-ray negative trials, these are the 4 trials that have been done. It's pretty similar. This one was a little bit higher, the Glimomab trial, but they also had a slightly higher placebo response as well. But if you look at it, it's roughly 40-50%, 40% response. And it's important that in X-ray negative disease, we're looking for objective signs of inflammation. So they did a subgroup analysis here in the first Humira trial where if you look at someone who either had a positive MRI or a positive CRP, statistically significant difference. If they were both negative, so no objective signs of inflammation, they were pretty close to placebo. Now, are there some subset here that we're not capturing? Probably. Like, I think I've had a couple patients who, for example, were on Humira for their psoriasis and their back pain got much better. MRIs and X-rays were all negative. They got switched to Stelara, which doesn't help the spine, and their back pain got much worse. And so I repeated the MRI, it was still negative, but he's convinced this back pain's much worse. So we put him on Cosentyx, which helps both spine and skin, and his back pain got better. So, probably has some inflammation, hard to know. So in summary for this first portion, think about spondylitis, spondyloarthritis in any young person with chronic low back or buttock pain. And many may only show evidence of inflammation on a stir MRI, and not conventional MRI. This is a fluid-sensitive sequence. Now, I'm not advocating that everyone go order MRIs on everyone with low back pain, because you need some other clinical features as well, because a lot of asymptomatic people will have a little bit of inflammation, and if you look at people with mechanical back pain, about a quarter of them have a little bit of inflammation, and they looked at professional hockey players, and 40% of them had a little bit of inflammation. So sometimes it gets you down the wrong rabbit hole if you order too many tests. So I want to talk about this study that we just recently presented at the ACR, the American College. So the point of the study was to facilitate early diagnosis of spondylitis and develop referral criteria for GI, ophtho-derm, so IBD, uveitis, or psoriasis, and kind of to stroke their egos, we called them the God group. And so we use this kind of low-hanging fruit because from previous studies we know that if you have a young person back pain, one of these extra-articular manifestations, probability of SPA is about 30%. And the hope is that we would come up with some questionnaire, leave it in the dermatology office, the patients would go tick, 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 and then this would say, you're 4 out of 5 or whatever, and expedite a referral to a rheumatologist. Secondary endpoints was to see what the impact of X-ray and MRI was on diagnostic certainty and what the impact of central reading was. So I mentioned in the Ability 1 trial, they had a separate read, and it was 30% were read as sacroiliitis. So in all the subsequent trials, obviously you learn from your mistakes, and so in the Symphony trial, they had a central read. They had expert readers. And so we were trying to see, does that make a difference here in our diagnostic certainty? So in this design, we had young people with one of these extra-articular manifestations and at least 3 months of undiagnosed back pain. They'd go through routine clinical care, so history, physical exam, B27 and CRP, X-rays, and then if the clinician thought it was appropriate, get an MRI. So the first bit, we take the history physical exam, and then kind of say, is it yes or no? And then we'd also see on a -10 to 0 to +10, what's our confidence? And then we'd incorporate the labs and the pelvic X-ray, and then what's our confidence there? And then add the MRI, what's the confidence? And then the fourth part is does a central read change that? And so we'd have to rate it. It's kind of a fun activity. Sometimes when the residents are in the room, I say, what's your probability, 0 to 10? And they'll say 2, and I'm like, no, you're wrong. Or not wrong, but that's your opinion, and it's 5 out of 10 or whatever it may be. And so these are the baseline demographics. So you can see here, back pain duration was 7 years. And most of them were 5 out of 10 or more. So most people would say that's moderate to severe back pain. About a third of them were on NSAIDs. Quite a few, about 13% were on TNF inhibitors, mostly because of the colitis or the psoriasis. Most of these patients are coming here from GI clinics, and the dermatologists were a bit lacking in their referrals for these patients here. And just kind of looking at, if you subdivide into who we ended up determining having spondylitis versus non-specific back pain, more males turned out to have spondylitis, and uveitis was a little bit more helpful. a little bit more suspicion if you have uveitis. The other ones were not that significant. Crohn's colitis was a little bit different, but numbers were small and it was kind of the other way around. And then, as I kind of mentioned before, these are all the kind of different questions we asked to differentiate inflammatory and mechanical back pain. And so they're all statistically significant, except response to NSAIDs. But these numbers, if you say, do you have any stiffness, 90% of spondylitis patients said yes, but then 80% of mechanical back pain also said yes. So that, I don't know if you feel that really helps you, but for me that doesn't. Well, what's kind of interesting is when you kind of have the clinician's gestalt, 82% of, if they said, yes, I'm pretty confident this is inflammatory, 82% of spondylitis patients have that as well, but 40% of mechanical back pain patients, the clinician was pretty confident this is inflammatory. So the history is not that specific. And another subset we looked at, we get the patient to tick off on the computer, is it better with activity? And then the rheumatologist ticks off, is it better with activity, to see is there some concordance there. And it was zero concordance. So the kappa values were 0.16 between what the patient said and what the rheumatologist said. And I think, if you ask someone, does your back pain get better when you're with activity? They might say yes with running, but not with walking, and better with yoga, but not with stairs. So it's really hard to tease that apart. The other feature we found was clinical exam, metrology, spinal movement, peripheral joint exam, not helpful. B27, very helpful. You'll see the prevalence is a bit lower than we might classically expect, but when you have patients with psoriasis or colitis, the prevalence is lower because you have more genetic driver. So we think, in classic AS, about 80 to 90% of people are B27 positive. If you've got colitis and Crohn's, it's about 60%. And we think, you've got a lot of gut inflammation, then that might be enough to trigger the immune system. And then, so you can see here, if you just looked at clinical exam, we, quite a few patients we thought had, like 67% we thought had spondylitis. But then when you start adding x-rays and labs, that number goes down. And then when you add x-ray and MRI, that number goes even further. And then when you get a central reader, then you're much more confident and you start ruling a whole bunch of people out. So we finally got down to about 30% of people having spondylitis if you had a central read. And so we tended to find that local readers tended to be more generous in their calling. Now, whether or not who's over and who's under calling, hard to say. But I think they're a bit more generous. And then when you factor that into the equation, then you tended to have less diagnosis. So conclusion here, there's a significant burden of undiagnosed spondylitis, even in high-risk patients. So, you got a patient with uveitis, 7 years of back pain. At some point, someone should clue in, maybe this person needs an opinion. And most of these patients had severe back pain, moderate to severe back pain. History is helpful, as I mentioned, but you kind of need a composite of things, and it's not specific. And there's a lot of inter-reader reliability, and physical exam doesn't seem to be very contributory in differentiating mechanical from inflammatory back pain. And then B27, X-ray, and MRI are the most helpful. So the other conclusions, imaging is primarily helpful in ruling out spondylitis and reducing our false positive rate, and then local reading may have more false positives than central reading. So I'll talk a little, any questions about that? I've been talking a lot. Clear as mud? Okay. So advances in imaging here. So I spent some time in Toronto working on getting some experience in spondylitis and psoriatic arthritis. And when I first got there, one of the studies we had ethics to do was to look at the CT scans of IBD patients, because they get CT abdos and pelvises, and that kind of gives us a free look at the SI joints, and we wanted to capture what's the prevalence of sacroiliitis in these patients. So I was all ready, we had ethics approval, and I was ready to go, and the radiologist said, what's your definition of sacroiliitis? Because CT is a very different modality than X-ray, and we don't have any good definitions. So we had to do an article on coming up with a definition of how do we define sacroiliitis on CT. So that was our first study. So some background, as I mentioned, imaging is fundamental in the diagnosis of spondylitis. But plain film X-ray has very poor sensitivity. Roughly at 3 to 5 years of symptom onset, only 50% of patients will be positive, and poor reliability. So we did a study looking at, there's 2,000 X-rays, and one person would read, and we'd get a second reader. And if you had, and we tried to see what's the concordance between the two reads. Obviously, if you're totally fused, it was a pretty good reliability. So if someone said, I think there's no SI joints left, it's a 100% agreement. But if the other person said, if one person said, I think there's severe changes, the next person said the kappa value is 0.8, so still pretty good. Once you get to subtle changes, so grade 2, then the kappa value is 0.3, or borderline changes or grade 1, the kappa value was still 0.2, 0.3. So when you're getting to these subtle abnormalities, the reliability is quite terrible. So CT is thought to be superior, but there's no validated definition of sacroiliitis, and it is more sensitive. So, this Volger et al. Had previously done CT scans in asymptomatic patients and found some sclerosis in 83% of patients, and what he defined as joint space narrowing, less than 2 millimeters, in 74%, which is quite high. And then a Japanese study looked at normal patients in the 40s and 50s, and once again found quite a lot of sclerosis. Almost a quarter had erosions, and then 94% had joint space, what he defined as joint space narrowing. So, previous studies have utilized CT to try to diagnose sacroiliitis, and they've relied on a radiologist gestalt, and they kind of just adapted the modified New York. So they said, I think this is the equivalent of a modified 2 or modified 3. And so the reported incidence of AS in these Crohn's patients in this French study was 45%. But then when you kind of dug down, asked the patients, do you have back pain? Most of them were asymptomatic. And the only symptomatic patients were generally positive for B27. So I think they were just overcalling things. And another study had suggested that this adaptation of the modified New York for CT just not appropriate. Now, while we think CT is a better test, traditional CT pelvis is quite a lot of radiation, especially to young people. And so there's been some concern about radiation exposure. But some patients that I mentioned, colitis patients, get CTs for other clinical indications, and it gives us a free look here. So we wanted to develop a validated screening tool to identify sacroiliitis in the on CT to ground future studies. So we took patients who had, most of these were colitis patients, I should say. There are 46 classic AS patients with CT scans of the abdo-pelvis from our Toronto Western Clinic, and then matched them to 46 controls. And these are young people who had CT scans for renal stones, because there's not a lot of other indications to get a CT pelvis for a young person. And then we reviewed their charts to make sure they didn't have spondylitis or uveitis or psoriasis or colitis. So we kind of divided it into a derivation cohort and a validation cohort, and we came up with some criteria on the derivation cohort and then try to validate it on the second one. And we had 2 blinded readers. So this is kind of busy, but basically what I wanted to say was that if you see a lot of ankylosis, I think you're done. That's quite diagnostic of spondylitis. If you see a lot of erosions, there's also like large erosions. It's very helpful. Or if you see a ton of erosion, so 3 or more, 5 or more, on this derivation cohort, you had a likelihood ratio of infinity and a negative likelihood ratio of almost 0. And then we ran it through with a bigger number, and it wasn't infinity, but the positive likelihood ratio was almost 14, and the negative likelihood ratio was 0.2, so not too bad. And these are inter-reader reliability, so it's a pretty reliable test if you get some training and some experience reading the CTs. And then we combine, excuse me, we combine a bunch of variables to see if we add sclerosis, is that going to add our diagnostic certainty? And so we didn't feel it really helped. You get more sensitive, but you lose some specificity when you add sclerosis in your equation here, this one there. So the conclusion was that the presence of ankylosis or a total erosion score of greater than 3 was useful for identifying sacroiliitis and may prompt a more timely referral to a rheumatologist. So then we applied this to 1,000 CT scans at the Toronto Western in the GI clinic, and 16% of those Crohn's patients had sacroiliitis, and I believe it was like 20 or 30% had ever seen a rheumatologist. So that prompted a bunch more referrals there. Now, a lot of them were already treated on a biologic, so maybe they didn't need a referral, and maybe that's why they were asymptomatic. So I'll go through some clinical scenarios where, in my own practice, I've found this helpful. We've been utilizing low-dose CT, so and I'm going to talk about this other study that we're trying to work on. So low-dose CT has actually got the same radiation as a regular pelvic X-ray, but resolution to 0.1 millimeters. And so, and it's not that expensive from what the radiologists tell me. It's $120. So it's certainly more expensive than an X-ray, but not as much as an MRI. So this is Mr. Time. I think I'm taking Com's cue to use herbs. So he's a 27-year-old gentleman who developed acute low back pain after a vigorous sneeze 4 years ago. So this back pain would radiate to his posterior thigh, no morning stiffness, it's better with activity, no improvement with rest. He does have alternating buttock pain, no nocturnal pain, so it doesn't wake him up from sleep. And there's a little bit of improvement with naproxen, but it's still quite severe, 7 out of 10. So, if I hear that kind of history, I'm not that convinced, right? Acute onset after a sneeze, I don't know, maybe he fractured something, maybe he twisted a muscle, and he's got no morning stiffness. So this really wasn't on my radar. And he didn't have any extra-articular manifestations. He was healthy. What prompted the referral was his CRP was 72, and it was 72 or at least above 50 a couple times we repeated it, and his B27 was positive. Now, that's kind of unusual. I don't see a lot of spondylitis patients with a CRP that high. I mean, there are some. I think Alice was the first one to tell me, if you see someone with a sky-high CRP and back pain, spondylitis on the differential. I don't know if you still believe that, but I think you told me that once. And so, in this case, that's a little bit unusual. Look for something else, for sure. Rule out, infections and whatnot, but which is another reason to get the MRI. But the X-ray reported as normal, and the MRI definitely did show some bone marrow edema on the right and some mild bone marrow edema on the left, but no comment on erosions. And so this is the X-ray here. You can see the left side's pretty good. The right side, that looks irregular, but it's hard to tell what exactly is going on. There's a lot of bowel gas here. And so I think the radiologist read that as normal. I probably would have done further imaging on this right side because this does look abnormal, but it could be just obscured by the bowel. And here's the CT scan. So you see this honking erosion on this side here. And so this is the axial, and this is the coronal. So yeah, some erosions on the inferior of the ilium. So in this gentleman here, we tried to rule out infection, didn't seem to have it. So we put him on a biologic, and he's much better, no pain. So that was one instance where, to kind of show the X-rays were negative. MRI, you wonder how specific is this bone marrow edema. There was some there, but the history is so non-convincing. Is this really spondylitis? But I think I'm a lot more certain given the erosions that I see there. The second case here, Mr. Basil, he's a 20-year-old gentleman. He's got a 5-year history of low back pain. Once again, so he's got insidious onset. It's unchanged with both activity and rest. He's got a little bit of stiffness in the mornings, alternating buttock pain, doesn't respond to NSAIDs. It wakes him up from sleep daily, but he doesn't get out of bed, and it's fairly severe. Now, interestingly, he's my cousin, my second cousin, competes on the national Brazilian Jiu-Jitsu team for the Philippines, and my aunt had asked me, see your cousin, he's got back pain, and I said, it's because he's pulled his back doing jiu-jitsu, right? It's not this, and then, and he doesn't have any extra-articular manifestations, no red flags, he's healthy, no medications, physical exam. He had a hard time touching his toes, but aside from that, nothing else. X-rays were reported as unremarkable. He had an MRI in the Philippines, which commented on mild bone marrow edema. And so when I saw him, I ordered a B27. Well, first, this is the X-ray here. So this one's a little bit suspicious. You can see some lucency here. Maybe that's an erosion. I would have called this maybe a grade 2. This one's a bit white here. I'd call that a grade 1, but it's certainly not diagnostic. And so this is the MRI finding. So this is a whiff of bone marrow edema. That's not a lot. And it was only on one slice. So technically that doesn't meet criteria for a positive MRI. And I would have said, this is nothing, or just wear and tear from your jiu-jitsu. But then, and this is the T1 where you can see there is evidence of fat metaplasia here. But they didn't see, looking back, I see there's a bit of hyperintensity here, but it doesn't look like an erosion to me. It happened to be B27 positive. CRP was normal. As I mentioned, grade 2 on the right, grade 1 on the left. He had a little bit of bone marrow edema, questionable erosion. So I ordered the CT, and he's got lots of erosions here. So he definitely has ankylosing spondylitis. Now, he unfortunately, he gave up his dream of competing internationally in jiu-jitsu. And I told him, we might be able to fix this. I think we could maybe get you back into competition if you want. But, he wants to treat this with meditation and diet, and, it's his choice, and I'm not sure how he's related to me, but nonetheless, he's still, he's gained a lot of weight because he's not exercising now because it's too painful to exercise, so it's a bit unfortunate. And the last thing I was going to mention on this imaging bit is we're trying to work on, as I mentioned, this low-dose CT scan and incorporate dual energy as well. So many of you have heard of dual energy CT scan for gout. And, a lot of the times you can tap the joint or you're pretty convinced they got a really good history of podagra. But we've had a couple cases of gout where, so for example, someone with rheumatoid who you're treating him and it's still, he's seropositive, he's got rheumatoid. You're treating him with biologics, but his joints are still swollen. So, order a DECT because who knows, maybe he's got gout and he does have gout. And so you treat both and that's how we get better. Or we had another patient who had a severe back pain. We thought it was discitis. And it was a gout protocol for whatever reason, and he had uric acid throughout his spine. And so we just treated him with colchicine and a little bit of NSAIDs, and he got better. So, we're trying to see if dual energy can be helpful. So you can see this is one of Tom's patients here. There's a lot of bone. This is a pretty severe bone marrow edema. So, obviously you start severe and you work your way, find out what your cutoff is. But if you can overlay the dual energy, you can see it lights up here as well. And so I think there's some potential there. You could do a one-stop, imaging. Of course, dual energy is not wildly available, but at least you can do the low-dose CT, get a good look at the erosions, and maybe some active inflammatory changes as well. And the amount of radiation on dual energy is 2 X-rays. So it's not too bad. So I'll talk a little bit about therapy here. So indications for therapy. Unlike in rheumatoid, a lot of AS patients, or spondylitis patients, I should say, do not develop severe X-ray changes and get this bamboo spine. So, in rheumatoid, we're all about preventing damage, because we know that, yes, the swelling is bad, but if you leave it untreated, there's a risk. They may develop irreversible erosions, and their function goes down with that, right? And not everyone does, but that's, untreated inflammation, there's a risk of damage. In spondylitis, that's not necessarily true. So we have cohorts where before the advent of biologics, and you follow them for 15 years, and a quarter of patients get that bamboo spine. About 30 to 40% get some degree of damage, but not a lot. And then the rest have 0 damage after 15 to 20 years in the spine. But a lot of them can still have a lot of disability. So the main decision to treat is based on pain and function. And we try to optimize with exercise and weight loss, but a lot of patients, it's still bad. If they're missing work, if they're cutting things out of life, then I would probably escalate therapy. We have a number of observational studies showing that TNF inhibitors likely reduce radiographic progression. We're never going to get an RCT, and so not all rheumatologists are convinced, but the challenge is this is a slow disease, and it would be unethical to put someone on placebo for 10 years and then really prove that, yes, TNF inhibitors did prevent it, but a number of sites around the world have demonstrated about a 50% reduction. But, it's a bit controversial whether to treat people who are asymptomatic or minimally symptomatic. On one end of the spectrum, I have a patient, a young guy, he's got severe back pain, he's bedbound, so we need to treat him, and his dad comes in with a bamboo spine, but he's a lawyer, and he plays tennis 3 times a week, and he's never had a day of pain in his life, in his back. So, if I caught him when he was 18, should I have treated him with, 50 years of a biologic? I don't know. Probably not. On the flip side, on the other end of the spectrum, one of the patients I share with Com, he had pain, but he never wanted therapy. He was kind of a bit paranoid about pharmaceutical companies trying to poison him, and so he never had therapy for years. And on his 40th birthday, he was slipping on champagne. He slipped, broke his neck. He's a quad now. And, he was asking the team for medical assisted suicide. So, that's one end of the spectrum as well. And these patients are at risk of fragility fractures, and we know that AS patients are at higher risk of cardiac mortality and cardiac events. We don't know if our therapies reduce that risk. And that's something that hopefully we can answer with, bigger population studies and admin database research. It's probably the only way we're going to get that answer. So, because broad strokes, non-pharmacologically, we focus on core strength and weight loss. And then pharmacologically, you can have NSAIDs, which are helpful, Some of the older studies said 85% of people respond to NSAIDs. Part of the challenge with that study or those studies was that we never had a good definition of what's an NSAID response. Is it any response? Is it I feel much better? Is it my pain's gone? And so if you look at NSAID naive patients with at least 4 to 10 back pain and you treat them with NSAIDs, about 30% of them will say my pain's pretty much gone. The rest will say it's still there and I'm still bothered by it. So it has a role, but quite a few patients need a little bit more. And I'm also referring to patients who end up in my clinic. So, there's probably a bunch of mild patients who do some yoga and the pain's gone and never make it to my clinic. And, that they don't need therapy, I don't think. And then biologics, the two that are approved would be the two classes would be the TNF inhibitors and the IL-17 inhibitors. And so it does give us, 7 options at least. And currently the JAK inhibitors, these oral medications, and now the TYK2 inhibitors will be investigated, which I think hopefully they'll show some promising results because I think oral options would be very nice, especially they'll get much cheaper down the road. So far, things like Stelara, Tremfya, risankizumab, and apremilast have not panned out, even though they help the bowels, they help the joints, the peripheral joints, and they help the skin. So, it's kind of, now we're juggling balls here because the TNF inhibitors treat everything, whereas IL-17 is great for the skin, good for the spine, good for the peripheral joints, but doesn't help the bowels, doesn't help the eyes. So, now we have to kind of figure out which areas are affecting that one patient. This is kind of a schematic looking at the American College of Rheumatology. So, needless to say, they divide it into active versus stable spondylitis. And this is before IL-17 inhibitors came out, but they said, if you have bad pain, physiotherapy, try NSAIDs. They don't care which drug. The number of RCTs show they're all equal, except atoracoxib's a little bit more effective, not available in Canada. And then from here, usually just go on a biologic if the NSAIDs didn't work. You might try a local cortisone shot in the spine. Say they've got real bad pain on one side. It's not unreasonable. The problem is it's not perfect. So there is an RCT showing it does help. About 70% of patients had a 20% benefit, which is not too bad, but it tended to come back 3-4 months later. I kind of use it more diagnostically. So if you're wondering what's going on, say they've got some subtle changes on one side, but not, the MRI is not that positive, I might try an SI joint injection. If it really helps, then I'd say, okay, let's do a 3-month trial of a biologic. Oral systemic glucocorticoids not indicated. So there's small RCT out of Germany. There's the placebo, 20 milligrams, 50 milligrams of prednisone. So the 50 milligram group had a little bit of benefit, greater than placebo. The 20 milligram group had no benefit compared to placebo. And the 50 milligram group, the minute you stopped it, everything came back. So generally, 50 milligrams, pretty whopping dose. We don't think there's much role for spinal inflammation using oral glucocorticoids. And then there's a bunch of things that are off-label. So there are a couple small studies looking at high-dose bisphosphonates or rituximab. They seem to be Edmonton-only phenomena because we've tried it in other centers and it doesn't seem to work. And then if it's stable, we try to get them onto a monotherapy if we can. If they fail multiple drugs, we often will add methotrexate or something like that to prevent subsequent failures. So as I mentioned here, no role for methotrexate or sulfasalazine, no role for kind of traditional DMARD for spinal disease. They can be helpful potentially for like peripheral arthritis. I mentioned the oral prednisone and the cortisone shots in the spine. So summary, I kind of wanted to give an overview of classification, how we make a diagnosis, some of the new imaging modalities, and different kind of broad strokes about treatment options there. And I wanted to give a shameless plug for the SASPIC trial, which is still ongoing. And if you have anyone with particularly an extra-articular manifestation or B27 positive, and they're young and they got back pain, we're enrolling for this dual energy study as well as this SASPIC trial, and we'd love to include patients if they're open to it. Thanks. Any questions? Yes.
No role for sulfasalazine in spondyloarthritis.
Well, good question. Good.
I mean,
Yeah.
that's what we always use before.
So there were no.
Some evidence.
So no, there isn't, but, well, I'll say,
No evidence for use of sulfasalazine.
in axial disease, no RCTs,
I realize it doesn't prevent
damage.
bone damage.
Yeah, so the,
Most of the insects
there are no, there's no RCTs that show it has any benefit. There's case series. There was one trial where etanercept versus sulfasalazine, and the sulfasalazine group had a bigger response than we might anticipate from placebo, but it was you knew you were on something, so it's hard to say.
I mean, I'm just going to say, I think it
Yeah.
was a bit dogmatic.
Fair enough.
We had our same issues with psoriatic arthritis because nobody did
Yes.
randomized controlled trials.
Yes.
And nobody did randomized controlled trials
Yeah.
until we had great drugs like biologics.
Yeah.
But if they're case series, it's still some evidence. And I think
Fair enough. I mean,
your patients,
yeah.
our patients are not, super disabled.
yeah, and that's a fair point. Or there's a contraindication.
It's something that's not.
Yeah, I mean,
I like sulfasalazine.
yeah, I hear what you're saying, and you're right. Because I guess absence of evidence doesn't mean no evidence. So
Oh, absence of
RCT.
randomized
Yeah.
placebo-controlled trial
Yeah.
doesn't mean absence.
Yeah. So that's a fair point. I think, and especially if you have someone with a contraindication, it's an option. Yeah. Yes.
So the spondylitis of other diseases is pathologically identical to the spondylitis of epileptic spondylitis?
Good question. So we used to divide it into like reactive, IBD-related, psoriatic. Pretty much yes. So in psoriatic, sometimes you can get this psoriatic spondylitis, or like in the C-spine. It's kind of unknown whether that is really the same because there are no studies that just look at that. No clinical trials in that group. And when I talk to different various psoriatic experts, spondylitis experts, and I said, "What's your gestalt?" And they say, "I've never systematically looked at it." And the problem is a lot of the times you put them on a biologic anyways because maybe their knee's swollen, and they're if it doesn't get better, you say, "Oh, it's just kind of mechanical pain." So that's the one exception: psoriatic spondylitis, and maybe different. And there may be some genetic explanations for that. So last year at the ACR, the Toronto group had divided those with spine alone or unilateral sacroiliitis versus bilateral sacroiliitis, and were there any genetic differences? And there were a little bit small signals for some HLA genes of one or the other, but nothing really you can hang your hat on. Reactive, I mean, in the textbooks they say you can have skip lesions, but most of the reactive arthritis patients that go chronic tend to behave like AS.
And follow-up question, enrolling in your study,
Yes.
are you suggesting that patients that have arthritis,
Mm-hmm. With back pain.
you have to have back pain?
Yes. Yeah.
Pointed out at the beginning that you need back pain for this diagnosis.
No. Part of the criteria is back pain. Now, if you look at people who, let me this one here. So the first step is 3 months of back pain at least to get you in. Now, there is such a thing as occult sacroiliitis. So, if you do imaging of people with uveitis with no back pain or a Crohn's patient with no back pain, a lot of them will have actually quite significant bone marrow edema with no symptoms, not on therapy. And in psoriatic arthritis patients, about a third of them, if you read their X-rays, show like pretty severe changes of AS, but only 15% of them have back pain. So we don't really know what the natural history of that, and I probably wouldn't treat those patients if they had zero symptoms. Now, the flip side to that is we do get some patients who say, no back pain, and even though their X-rays are abnormal. And then someone puts them on a biologic for their skin or the bowels, and they say, oh my goodness, I'm a new person, my back pain's gone. And I said, I thought you had no back pain. And they said, I forgot what normal felt like. So people, because this kind of creeps up on people, sometimes you do get that. And I'm not at the point where I would just treat people purely based on imaging. It's a discussion to make. Yeah. Any other questions?
So if there are no other questions, I want to thank Dr. Chen, but before he leaves, to make an announcement. Next week's neurology round, so please come and hope you have as good attendance. Thanks, Jonathan.
No problem. Oh, thank you. Yeah. Yes. Yeah.
So do we know that if he had received treatment, that his spine would have been more, like, I guess that's my question.
Oh, if it's already fused,
Yeah.
hard to know. I mean, we don't know if, because there, I'll take this off here. There is an increased rate of osteoporosis. They get a lot, like I have quite a few patients who like sneeze and their neck breaks, or they go over like a speed bump. And I don't think we know if our treatment would prevent that osteoporosis. It may be from inflammation, but it could also be another theory is that if they're not mobile, that they're not getting the bones, not getting the stimulus to strengthen. So it may just be that, and if they're fused already, then they need to
So it's not, like, I guess that's it's so sad though, right? What ended up happening?
Thanks for attending. So for him, he's a GS strong, and I've kind of reached out to say, you want to come over, and he's like, I'm not emotionally ready. So, which reminds me, I should probably invite his family in and see if he's open to
So sad.
Yeah.
It's also interesting now to focus on systems and function.
Yeah, I think it's a bit more unknown. I think.
Yeah.
I think the Europeans are
More aggressive?
they call biologics NSAID-sparing drugs.
Oh, that's really interesting. Like we do steroids.
Yeah, so I think that's a bit aggressive because there's risks with biologics too,
Sure.
not just money, and so
But the infection part and malignancy and
yeah.
you don't know.
So I think it's a big up in the air still.
Yeah.
Yeah.
Very interesting.
Yeah. Thank you.
Thank you so much.
So I
Can
saw-
use your pen?
Yeah,
Thank
I
you.
saw
Sorry.
a woman just the other day with arthritis. And
Yes.
just-
Mm-hmm.
But I'm actually thinking now of doing it in Rwanda.
Sure.
I mean, she's young and
Let me know the result, and
Yeah.
if she's interested in enrolling in a study, then
well, it's just the I mean, there's usually an etiology.
Mm-hmm.
I mean, it may not
Yeah.
change your therapy. At this
Yeah.
point.
Mm-hmm. Is she B27 positive or no? Oh, okay, that's another thing. Usually there are some exceptions, but usually uveitis from spondylitis is B27 positive. No.
Thanks so much.
Thank you.
That was really
Thanks.
interesting. Thank you.
Can you come help us now? Nah.
Your call will be disconnected.